All right, everybody, this is another vignette, another case study. I'm going to go ahead and leave it blank and show you the entire vignette if you want to kind of put pause and take a screenshot or whatever you want to do. Then if you want to follow along, that's great. If not, you can kind of skip through this first minute or 30 seconds to see the vignette, and then I will start. So hold on a second, I'll show you the vignette. Okay, we're back. Now that you've had a chance to look it over, let's dissect the vignette. So let's go through. Here we're working with or viewing the case of a 32-year-old married woman, Christy, and she works as a department store or a sales clerk in a local department store. Looks like she's been mild to moderately depressed and anxious most of her life, so we have that as a kind of symptom or background. And then a few years back, it looks like she's been having stomach discomfort, which is just a clinical side note. Usually stomach discomfort and pain, anything that has to do with like the GI, gastrointestinal stuff, is kind of commonly can be associated with like anxiety, usually anxiety-based kind of disorders and depression. But I would say mostly anxiety really kind of wreaks havoc on gastrointestinal issues and ulcers and all sorts of stuff, and nervousness often, and anxiety can cause like IBS, irritable bowel syndrome, constipation, all the other stuff, and this can be a major factor in a person's life. It can be very uncomfortable, and so oftentimes they do seek help from a family physician. And so this is where this lady ends up, as she goes to her family physician, and he makes a diagnosis, which is kind of an interesting diagnosis, of nervous stomach, which I ran that past my wife, who's a nurse practitioner, and she's kind of like, I don't know about the nervous stomach, but it could be in the realm of anywhere of kind of an ulcer or something like that, IBS, something to that effect. So it looks like he doesn't find much because it looks like very soon after, he refers her to learn how to manage stress. And then he does something which is normally, it appears to be kind of uncommon for this particular kind of treatment. Normally, nowadays, I think this vignette is done. I got it from a book that's, it's probably 15, 20 years old. So maybe back at this time period, this would have been normal. But I would say nowadays, for something like a stomach issue, prescribing what he prescribed, diazepam, which is Valium. Normally nowadays, the benzodiazepine class, the Valium, the Ativan, the Xanax, the Klonopin, that's usually only now prescribed for panic attacks and or kind of significant sleep issues that a person needs to kind of get to bed at night and kind of completely relax. But other than that, he gives her diazepam, Valium for this nervous stomach to help her, and told her she needs to learn how to manage stress. So that starts off this case scenario, mild to moderate depression, anxiety. She now has kind of nervous stomach and is given Valium. So let's see where this case goes from here. All right, let's jump into this next part. So the doctor goes on and cautions her to use the tranquilizers as he prescribed them, which is great. That's what you should do, which is typically, for something like a benzodiazepine, usually it's prescribed a certain amount of times per day, but mostly as needed up to a certain amount of times per day. And nowadays, usually it's a pretty small dose in order to just help that person get over the hump of anxiety that they're experiencing. So he tells her to take them as he prescribed. She found them helpful in reducing her anxiety, which from my experience, I would say the vast majority of people who take benzodiazepines or are put on benzodiazepines definitely feel the effect. That's part of the problematic nature of them, is that they're really effective and they do the job, but they almost do it too well to the point where, wow, it's a person experiencing any sort of anxiety or early panic, they take one of those, and I call it the fire extinguisher effect. it does its job to bring down the physiological aspect of it, which does obviously provide some mental, psychological comfort of, oh my gosh, I'm no longer feeling that discomfort, that anxiety. So from the human point or human perspective, I mean, that's great. I'm in the fact that we don't want people to kind of suffer, and yet kind of that discomfort and learning how to cope naturally with it is also where things become very difficult for us as counselors, because the medication is almost always going to win out as far as applying the skills and the effort. It's a lot easier to take a pill and feel the effects than it is to kind of live with the discomfort or manage the discomfort through mindfulness, through breathing techniques, through progressive muscle relaxation, all of those things that we teach clients. Those are all wonderful, and we're shooting for the long run perspective, the long term perspective of teaching them coping skills, that life is always going to kind of have some sense of discomfort, some sense of distress, anxiety, and how do you begin to manage that and live with it while using these coping skills? But those require a lot of effort, time. They're not immediate as a benzodiazepine. So as we will see here, that's kind of what begins to happen, which is typical in the field, and you might as well really kind of know this case scenario, because a lot of you will see this time and time again. This is kind of a classic kind of play out of what happens with people oftentimes that get on benzodiazepines, and then they find themselves in this scenario. So she found it helpful, although it says it made her drowsy, and she had some difficulty concentrating on her work and driving, which is a pretty common side effect of benzodiazepines. There is kind of this drowsiness. It's difficult to concentrate because the mind is really kind of loosened up, so to speak. It's really relaxed, so it can be difficult to be sharp and on task. I mean, anxiety and stress, we need that little bit of anxiety and stress to keep those kind of chemicals that our brain produces, the cortisol and all of those things, in order to kind of heighten our alertness to stay on task. Stress, little amounts of stress are helpful to us as humans. And then obviously driving, you don't want to be impaired when you're driving, so depending on the dosage, that's why patients, if they ever ask you as clinicians, well, can I drive on this? Definitely defer to the physician and or a pharmacist. Don't take on this kind of responsibility to say, you know what, as long as it's a small dose, or just defer it back to their primary care provider or psychiatrist or pharmacist to have them make all of those calls. I would say, just as a side note, similar to side effects, it's one thing to say, like, you know, yeah, I've had some clients that it causes some drowsiness and concentration, but definitely I would say definitely don't come out and portray yourself as an expert, or begin to go down the line of, yeah, let me tell you the side effects, because you may miss one, you may be misinformed of one, you don't know their other medications and how they may interact. So it's best you just say, you know what, that is something that your prescriber or your pharmacist, they know all the interactions, they know all the side effects. That's kind of beyond your scope of practice as a mental health, as a licensed clinical social worker and mental health provider. So don't be afraid to just kind of shy away. Again, it's one thing to kind of be like, well, there's some clients that talk about drowsiness, but as far as relating side effects to them and them wanting to know all the side effects, they may have a medication that it may interact with that you don't know about, and you can get in some big trouble. So that's kind of my side note. So it goes on to say that after a few weeks, she tries to decrease the amount of medication, which this is also very common. You have many people that have kind of this noble and kind of reasonable and rational insight to say, you know what, this has really helped with my anxiety. I'm going to try and kind of decrease this and get off of this. This is the original plan, is to usually not be on this long term. Especially benzodiazepines, this is typically not prescribed as a long-term solution. Normally it is to get people past this kind of difficult time period. And then usually the long-term trajectory is to, if anything, put them on a long-term like antidepressant, anti-anxiety, such as an SSRI, something that is what we're talking like maintenance level, to where it's just in the background. I kind of call it, it's kind of silly, but I call it kind of elevator music, where you kind of know it's there, but it's so subtle that it's working, and people usually are calmer, but it's not the calm that benzodiazepines give you. It's just you're less reactionary, less agitated, less kind of on edge, more able to handle things, more able to focus. But it's this really subtle effect that can take anywhere from like 3 to 6 weeks to kick in. And so for a lot of people, being on benzodiazepines is much quicker. But this is the problem with it, is it is so effective that they want to return to it more and more. So she tries to decrease the amount, and yet each time, and I'm going to change the highlighter, this is more symptomatic, each time her anxiety returned, and she continued though to follow the doctor's recommendation, seeing him every few months to check up. So that's great. She kind of, the anxiety comes back, but she continues on this path of saying, hey, I'm going to follow the doctor's prescriptions as ordered, which is what we want our clients to do, is follow the medication management plan, not change it up on their own. That speaks to other issues. So as time went on, it says the effects of the medication seemed to wear off. So this is kind of the beginnings of a slippery slope, which they do. The word in, whether it's in health, mental health, they start to build up a tolerance, is what it's typically called. The body's not getting the same effect because of, the time that now the body has become accustomed to that dosage. The nerve endings, the neurotransmitters, all of those things have become now adapted and accustomed to receiving that dosage every day. The body's going to want more of it in order to achieve the same effect. So she's not feeling the same effect, and she found herself taking more, and I'm going to highlight that, taking more than prescribed. So here is where the vignette, the case scenario, starts to take a turn for the worse. She starts to take more than prescribed, which is very common out in the clinical world. She then asks her physician for more medication, but he was reluctant to prescribe a larger dose. And this is very true, having worked in a clinic for pretty much my entire career. This is what happens. The client returns to the provider, asks for more. The provider usually is reluctant. However, they're human beings as well. They also operate similar to kind of social work and other human service providers and medical providers, in that we don't want people to suffer. We don't like to see people in pain or discomfort. So although reluctant, which is kind of the gut feeling that says like, this doesn't seem like a good idea, he goes on to prescribe a larger dose, which, as I just talked about, this larger dose is to make up for the tolerance that the body has built. So after she had been prescribed, or after she had pestered him, after she had pestered him with several telephone calls and unscheduled appointments, he increased her dose. So this, when it comes to what we're talking about, is a couple of different things, and I didn't identify this. So she's increased her intake or usage beyond what was prescribed. So this is kind of the early criteria for substance use disorders, when you start to take more than you're supposed to and you increase it because of tolerance issues. So you're beginning to develop a tolerance, you increase your own dose, and then she starts to pester the provider. So now you're spending additional time seeking out the med or substance. So we've already got a few criteria building up here, as you can see. And as we go along, we find out the additional medication helped and her anxiety diminished, is this next little sentence, although the drowsiness increased. So, that's pretty typical. You're taking higher doses of a benzodiazepine, which has that side effect of drowsiness and issues with concentration, all of that stuff. Coordination becomes a problem. So here we go. A few months later, she started feeling more anxious and found herself increasing the dose on her own without talking to the physician. So we have an increase in anxiety, and then this is also common of what happens then. She kind of starts to be her own kind of medical provider, and she tells herself, you know what, I'm feeling more anxious, therefore more anxiety means more medication, as kind of that's the way the human brain works. It's smart enough to know, oh, if I'm having more anxiety, that must mean more medication is better. And again, so what we have happen is similar to this first little step, which is she increases her usage because of the tolerance she's built up. She finds herself, the drowsiness increased. She began to experience slight impairment of coordination. So all of this becomes problematic, whether you're at work, whether you're driving, whether you're at home doing things. It now kind of puts you at risk and impairment. She was now using the medication faster than the physician prescribed it. So again, this returns to this other point there, which is in the beginning, or shortly ago, she kind of doesn't follow the plan. I'll just put the medication plan. That's when again, patients are kind of going out on their own. They're not following through on it, which is where things start to kind of get dangerous and out of control. So interestingly enough, she calls him and asks for more, which it's pretty bold, and yet at the same time, this is very common when you start to have habit-forming substances, addictive substances. At this point, the insight starts to kind of go away, the consequential thinking starts to go away, and they're just so kind of beginning to get desperate to have that relief that they're willing to kind of burn a bridge, so to speak, in order to get the medication or the substance, in order to get the relief. As far as normalizing that, again, it's the human body, the human brain, and physically, I mean, that makes sense from their perspective, is you want the relief, and that provided you with the relief, so you're going to do what you can to get it. However, that process of returning to get it over and over again and pushing the limits when the doctor has already said, like, no, I'm reluctant to, but I'll give you a little bit more. Now she's returning back. So the physician was even more reluctant than before to prescribe additional medication, but finally wrote her another prescription for the same dose and told her he would not increase the dose. So the doctor at this point, I mean, this is where you do burn a bridge, is when you've pushed the limits of your prescription, you push the limits of kind of that relationship where you've returned. He's told you, hey, this is to the point where I'm at. I'm not comfortable, but I'll prescribe it at this dosage. And so she's kind of pushed to the limit at this point. So here's where things also get interesting, as she starts to feel ignored by her doctor. And again tried to decrease the medication on her own. So I think in desperation, a moment of insight to say, hey, this is getting out of hand. Look at what I'm doing. I'm going to try and decrease this again, which when you've increased your medication and you've increased your tolerance, trying now to decrease that, you're going to have kind of what's called rebound anxiety, which is if you try and get off of this, you are going to feel a pretty steep increase of anxiety again, because your body's going to start to panic when it doesn't have it at the same dosage that it has before. So she starts to decrease, And then, similar as the previous attempt, it says her anxiety soon returned and seemed worse than before she started the medication. So, like I explained, it's there's a term out there called rebound anxiety, which is that it's almost like this bouncy ball where it goes down and then actually kind of bounces back up almost higher than it was previously before. So now her anxiety is worse, which causes people oftentimes to panic worse and feel anxiety more. So she makes an appointment to see the doctor, the physician, at a nearby community, and convinced him to give her a prescription of diazepam. So here we have this other kind of criteria or other type of behavior where you're all of a sudden you're what they call doctor shopping or kind of seeking behavior. Where you already have established care, you already have a prescription, but because of the desperation, now you're willing to go out to a nearby community and convince another doctor to give you a prescription for the same thing. So now she's got a double prescription. This was the first in a series of visits to new physicians. So now she's got new physicians and a local hospital emergency room for where she asked for diazepam. So as you can see, now it's become very excessive. She's not only gone to one doctor, now it's multiple providers. Including the ER. Which I was going to get my wife on video. She was going to kind of be my side commentary person to speak from the emergency room perspective of this is really kind of what becomes the case is when people cannot get a sufficient amount from their primary care or they've kind of doctor shopped and burnt their bridges out in the community. The ER ends up being kind of their final stop to try and get even just a couple of pills. And it definitely puts those medical providers in a very difficult situation because by that time, a lot of the patients are so desperate or going through withdrawals or going through a severe panic attack that they do kind of give them something to calm them down, and then maybe a couple of just a handful maybe of additional pills, not a full prescription oftentimes, to get them back into the community to establish care again. But it's at this point now it's a revolving door. So soon she was spending a significant amount of time driving around the community trying to obtain tranquilizers for various sources. So this is another criteria is, again, you're spending increased amount of time trying to seek out that particular substance. She continues to pester her own doctor for medication. So she's burning bridges out in the community among medical providers, which is this is the wrong route to go because once you're labeled, unfortunately, as a drug seeker, it really kind of makes its rounds out in the medical community. There's red flags all over. There's notes being put in the medical record saying beware of this particular person. She's been doctor shopping around the area. So the word eventually gets out. After several months, her family physician told her he was uncomfortable continuing to prescribe the diazepam and suggested she would benefit from seeing a psychiatrist, which is essentially passing the buck, which a lot of medical providers at this point are like, okay, go see a psychiatrist. You need more kind of mental health help than I can give you, which is appropriate. But again, it's kind of funny because this is real world. They kind of say, hey, it's time to go see the mental health specialist, which at that point, the psychiatrist is left holding the bag going, what? You essentially left me with a person who's addicted to or has become dependent on benzodiazepines. So Christy was angry, protested that she didn't need psychiatric care. So you can tell that her response isn't within kind of a typical response of like, oh, I need additional help. Well, thank you for the referral, blah, blah, blah. It's more anger that a boundary has been set. And the recommendation for additional psychiatric care obviously it seemed like it insulted her, accused the physician of trying to abandon her. So this is kind of the last straw that a lot of people use, is they pull out kind of the ethics card of saying, if you don't give it to me, I'm going to consider you abandoning me, which is kind of pulls at the heartstrings and pulls at the ethical strings of multiple professions, including counselors and clinical social workers. Once you throw that abandonment card out there, things get kind of sticky. However, you've got to have a boundary. You've got to draw lines. You can't continue to kind of enable this behavior. So the doctor insisted, referred Christy to a local psychiatrist, which is appropriate, along with a note asking the physician to prescribe her with diazepam, which that's what's kind of interesting, is he kind of threaded the needle with her and said, hey, let me write you a note. I will include a kind of a stipulation that says, hey, I'm going to refer her to you, and please prescribe her this particular medication, which I would think any sort of psychiatrist or another medical provider might look at this and go, oh my gosh, are you kidding me? So Christy was reluctant, and she made the appointment with the psychiatrist. When she met, they met, she gave him the note and began to explain that she was only seeing him for medication. So she's already starting off kind of barking up the wrong tree and going down the wrong route with the psychiatrist. The psychiatrist was non-committal and asked about the personal problems that led her to the referral. So the psychiatrist, as I said, this is probably not his first rodeo, and he realizes, no, this is not a typical referral. They spoke for about an hour at the end of the session. He concluded that Christy was depressed, which is as well as anxious, and offered to prescribe an antidepressant medication, which I said in the beginning is typically the route that most people will go, unless it's severe panic or something to do with kind of, severe sleep issues. Most of the time, prescribing an antidepressant or an antidepressant with anti-anxiety type of properties is usually kind of the course of treatment, typically, because of the habit-forming and addictive effect of benzodiazepines. So Christy, usually not being sold on that, because they know at this point SSRIs are not benzodiazepines. So she asks about the diazepam, and the psychiatrist replied that he would not prescribe the tranquilizer, which I'm sure she was not very happy at that point. Christy pleaded, saying, here we go, this is where it gets back to this idea of not really having the insight of what this is actually, it's actually going against her cause. This pleading, begging actually shows that there's an addictive independence or addiction and dependence going on, as opposed to, please, help me alleviate this. I'll use it responsibly. It says, what do I do when I'm anxious? I can't even sleep. Psychiatrist states, in my opinion, you don't need a tranquilizer. So this is a pretty strict, or at least pretty firm psychiatrist in knowing, nope, this is not appropriate. Christy was furious, took the prescription for the antidepressant medication and left, and she continued to seek tranquilizers from various sources, including her family doctor including the family doctor. So the psychiatrist set a boundary, actually came out and told her, which is really bold, but necessary. And I've seen that in my previous, where I worked, clinic, where they come out and say, no, you don't need it. What you need is an antidepressant and counseling. And most people don't like it at that point, especially if they've have some sort of addiction going on. So this scenario, this last little bit is a few sentences long, and then we wrap it up. All right, so let's wrap this up. So this goes on for the next several months. She begins to see the psychiatrist and take the antidepressant medication, which is a great sign. That's what we want her to do. That's on the right path. What's interesting is this last statement here, that her use of tranquilizers remained the major topic of discussion in her sessions with the psychiatrist, which is kind of interesting, and that's kind of to be expected. I think there's always this tension, especially once somebody has kind of had the effects of a benzodiazepine and has known how powerful it is and how effective it is, that there's this tension between the provider and the client, which is kind of like, I'm going to take these antidepressants, but I'd still like these benzodiazepines. And the medical provider is typically like, nope, just stay on the antidepressants, go see your therapist, and no more benzodiazepines. And yet, like I said, it's this going back and forth of the client wanting to kind of try and convince the psychiatrist, and the psychiatrist pushing back, or the medical provider pushing back. So that's kind of the way things play out normally in the real world. So what I'll do is I will go through the criteria real quick and kind of check those off and make sure we're on the right track for substance use disorder, which the official diagnosis would be the sedative, hypnotic, and anxiolytic use disorder. But let me load up the criteria. We'll check those off and make sure we're on the right track. Okay, let's look at the criteria and see kind of what we've come up with. So we know she's taking an benzodiazepine, which in this case is considered an anxiolytic drug. So what it says is that a problematic pattern, right, of sedative, hypnotic, or anxiolytic leading to clinically significant impairment or distress by 2 of the following. So only 2 in a 12-month period. So that's quite a while. So here we go. The first one, this group of drugs, anxiolytics, are often taken in larger amounts over a longer period of time than was intended. So that we will check that, as she increased her dose longer than she thought and larger amounts than was intended. There's a persistent desire and unsuccessful efforts to cut down. That is check. A great deal of time is spent in activities necessary to obtain the anxiolytic. And then, use the anxiolytic or recover from its effects. So check. Craving or strong desire or urge to use. I would say that clinically, yes. If she's calling and pestering, that's probably the case of a strong desire or craving. Recurrent anxiolytic use resulting in a failure to fulfill major role obligations. Repeated absences from work, poor work performance. That's probably the case. We know that there was some issues at work, so we'll kind of put a check question mark. We know that it was causing some difficulties there. We don't know too much about home, but we know that there was certainly some stuff going on. Continued anxiolytic use despite having persisted or recurrent social or interpersonal problems caused by or exacerbated by the effects. Arguments with spouse, consequences of intoxication, physical fights. I didn't really see much of that. If we want to call interpersonal problems part of the kind of doctor shopping, doctor getting kind of irritated and frustrated with her, that may be the case. So I'll put kind of a check question mark, because that certainly could be the possibility. Important social, occupational, recreational activities are giving up or reduced because of the use. We really don't know much about that. That's kind of a question mark. Recurrent anxiolytic use in situations when it is physically hazardous. Driving an automobile. Again, we know that she's driving. That one again is kind of almost a check question mark. We know she's driving on it. We know that there is some difficulty. I'm not quite sure the extent of physical hazardous, other than possibly driving and not knowing too much about it. And then the anxiolytic uses continue despite knowledge of having a persistent or recurring physical or psychological problem that's likely to have been caused by or exacerbated by the anxiolytic. So this one I would say is a yes. The doctors have told her, no more, or I'm not going to prescribe more, or here's an antidepressant, and yet she still wants a tranquilizer. So I would say that's a yes. And then finally, tolerance is defined by the following, either of the following. So you've got to have 2 of those ones above, which we've had, 1, 2, 3, 4, 5 at least, maybe 6 or 7. And then this tolerance question, a need for marked increased amounts of the anxiolytic to achieve intoxication or desired effect. or a marked diminished effect with continued use of the same amount. So I would say kind of both of these. She needed more to achieve, and there was a diminished effect with continued use. She wanted to go back and get more because it just wasn't taking care of the anxiety. So that is the diagnostic criteria. So she certainly met at least 5 or at least about 7 at this point. So let's see this final page and determine the outcome. Okay, so here's the final page here. This isn't really a withdrawal situation or intoxication situation. This is more of determining this generalized pattern of usage. And so we're kind of moving beyond 11, that criteria, number 11 there, of judging withdrawal syndromes there. So we're going to move past that because that's just not where we're at in this particular scenario. Let's see. We know that when she does try and withdraw from them, I guess I could say that. We know when she tries to go off of them, we know that she feels more anxiety in which she has to return to take more. And so, that's really kind of criteria, both A and B there, is that they're taken to relieve or avoid withdrawal symptoms. So that's kind of, I would say, within the realm certainly of withdrawal characteristics, that she has that pattern of as well. She tries to get off of them and then realize, she needs to take more. So she's not in early remission. She's not in sustained remission. She's not in any sort of controlled environment, such as an inpatient. So now we get down to the very bottom where we're basing it on severity. So what we're looking at are these areas here, whether or not it's mild, moderate, or severe. The level needs to be either 2 to 3 symptoms, 4 to 5 symptoms, or 6 or more. And I am going to, kind of based on what I marked, I'm actually going to put it, at this point, I think I'm going to put it at severe. I think she's got quite an issue with it. She was on the border of kind of 5 or 6, but then if you get to number 10 and number 11, again, I think those are kind of additional characteristics that show that this is a pretty serious problem. So at this point, I would probably just do severe. I think with a little bit more probing questions, those ones with the check marks would have probably turned out to be a yes, or with a little bit more history. So it would be F13.20, which is, we would determine it is the sedative, hypnotic, and anxiolytic use disorder, severe, with the presence of 6 or more symptoms. So that would be my diagnosis for this particular case. Hopefully that was helpful. This is certainly a real life kind of example and pretty typical scenario that you will face as a clinician as you see folks that struggle with using benzodiazepines or getting on benzodiazepines, being prescribed early on, and then struggling to get off of them as they realize that it works kind of so well for panic disorder and or sleep, that it is a big issue, and it does form a habit both physiologically and psychologically to get off. So it can become very challenging for us as clinicians to teach them the skills to be mindful and to actually kind of live with that discomfort and be able to manage that anxiety or to cope with it through the means that we teach them, whether it's cognitive behavioral, whether it's mindfulness, whatever route we want to go. It can be very difficult for them other than quickly taking a pill. So this is a great case to look at and study, and hopefully it was helpful.